So it's showing a loading button, preparing to live stream the meeting.
We got the notification also. We are live, ma'am.
We're live?
Yes.
Okay, sure. Yeah. Okay. So I'll just start the thing. So my screen is visible, I hope.
Yes, ma'am, it's visible.
Yeah, and I'm audible.
Yes.
So I'm getting an echo.
Ma'am, your voice is completely fine. You can go ahead if you're comfortable.
One second. So the thing is that, so very good. So very good evening, everyone. Welcome. Good evening, everyone. So on behalf of the Yosi team, I welcome you all to the Yosi Journal Club session, the September session. So the basic concept of the Journal Club begins with the say, publish or perish. Very, very dynamic team of see Dr. Digvijay Singh and President Dr. Sonal Kalia. Dr. Sonal Kalia will especially mention and thank who's been the pioneer for setting up this Journal Club session and has been the guide force behind this. Was with the secretary being very helpful in conducting the sessions. The executive member, dynamic executive member. So the concept of the Yosi Journal Club began from, when you are a young ophthalmologist, right from a postgraduate year one to a postgraduate two, you have different questions in mind. So, with we wanted to sort of sort out how do you interpret a journal article, how do you read between and help understanding. So, the Journal Club is basically assessing the with respect to definition of the problem, specification, definition of variables, selection of subjects, research design, analysis of data, interpretation. The MARI format, which is a step-by-step interpretation or the analysis of which we will cover in detail. So the format of the Yosi Journal Club, we have a presenter or a speaker, generally a fellow or a postgraduate student who presents the assigned article under the guidance of a monthly mentor. We have a research expert who related to the article. We have a moderator who moderates the session, and then we have expert panelists from the field who give their take on the article and give the positive and negative aspects of the article along with the recent advances. So coming to the MARI format, so the MARI format is basically step-by-step analysis of the article with respect to the method, assignment, result, interpretation, and so a step-by-step approach to reading the medical evidence. So we basically have floated this Google form. It began with floating this Google invited applications for presenters. So those who further wish to present or participate in the Journal Club sessions can email your interest or present suggestions to the email ID. And so we've had a very successful run in 2021. We had a session in glaucoma, followed by a session in endophthalmitis, and a cataract surgery, then oncology, pediatric ophthalmology. Then 2022, we started with the oculoplasty article in August on thyroid eye disease, followed by glaucoma article. We had a very interesting last month. And today's session, we have a discussion. So the article for discussion is effectiveness of the video game versus placebo video game for visual functions in older children, teenagers, and adults with amblyopia. Randomized control trial was published in the JAMA Ophthalmology, factor 0.253. So we have the research expert for today, Dr. Modi, who's also very. We've had a long association since UA journal. He's been helping us with statistical. So Dr. Rohit and Hospital Mumbai. Then on the expert panel, we have very dynamic Dr. Asha. Dr. Kirandeep Kaur, who's at Punjab. Then for the monthly mentor, we have Dr. Gunjan Business Center, Chhattisgarh. Presenter for today is Dr. Anjali Maheshwari. She is doing her MS from Command Office Air Force, Bangalore. She has 6 PubMed Index articles and was certified by IGF for one of the 21. She has interest in pediatric ophthalmology and methodology. So the moderators are Dr. Anujit Paul. So he is his MS from Mahatma Gandhi Medical College and Research Institute, Pondicherry. He has 11 articles and is the recipient NOA Gold Medal Reviewed Publications and the Platinum Award of 2021. He has interest in retina surgery, cataract refractive surgery, and research methodology. And myself, Dr. Nupur, I'm a consultant and I am an executive member and cross times. So, before we really move to the article, we have a very interesting audience quiz by Dr. Anuji. So I'll request him to take over and start the audience quiz. Stop sharing my screen. Anuji. Anujit, you are on mute.
So sorry, ma'am. Thank you so much, ma'am, for that lovely introduction for the Journal Club. It is indeed a pleasure being a part of the Yosi Journal Clubs. So this Yosi quiz is a short warm-up to the actual presentation that is coming up. So if anyone from the audience knows the answer to the questions that I'm about to ask, just put a small signal like an I or something in the chat box, and we'll ask you to unmute yourself and you can tell us the answer. It's a very simple quiz. It's just for jogging and refreshing our memories right before the Journal Club. So I'll start off with the first question. So what is the critical period for visual development? So option 1 is 1 to 2 years. Option B is 4 to 5 years. Option C is 6 to 7 years. And option D is 10 to 12 years. So I'll just wait for about a couple of seconds for somebody to log in and tell us the answer. So if you know the answer or if you think you know the answer, just put in a message in the chat box. So would anyone like to venture a guess from the esteemed panel or the presenter? Right, so let's just have a look at the answer. So the critical period for visual development is from birth to about 6 to 7 years. And during this period, a child's visual system is most vulnerable to abnormal input, and a child can regain vision with abnormal treatment up to this age. Moving on to the next question, another very interesting question. When should screening for amblyopia be carried out? Option A is by 6 months, option B is by 1 year, option C is by 3 years, and option D is by 6 years. So once again, you can put an answer in the chat box, or you can unmute yourself and try to answer. I'll just wait for about a couple of seconds before I reveal the answer. If anyone from the esteemed panel would like to venture a guess, I'm sure everyone knows this from the panel. So there is one reply. It's from Kirandeep ma'am. It's option B. So let's just have a look at the answer. So the American Academy recommends screening to be done by the age of 3 years and thereafter every 2 years. Whereas for children, dilated fundus examination should be done, along with visual acuity, corneal reflex testing, refraction, visual fixation at 4 to 6 years, screening for congenital cataract, at 4 to 6 months, screening for infantile esotropia, and 4 to 6 years screening for intermittent esotropia, refractive error, and nystagmus. So this is actually like a full toss ball in the middle of the match. It's a really easy one. What is a classical clinical feature noticed while testing for visual acuity in amblyopia? Is it A, entoptic phenomena, B, crowding phenomena, C, jack-in-the-box phenomena, or D, Puthoff's phenomena? So once again, you can put your answer in the chat box. I'll just wait for a couple of minutes. Dr. Anjali has guessed, and no surprises there. Yes, definitely. She has guessed option B, and the classic feature in amblyopia is crowding phenomena, and that is the inability of the amblyopic eye to discriminate optotypes that are crowded together. So this is another interesting question that I found. I thought I'd share it with everyone because it was new for me as well. So what are Bangerter filters? So any explanation from the audience or from the panel would be very interesting. This was a learning question for me as well. So I've put up whatever I know on it. So I'll just give it 5 seconds and then I'll share the answer. So they are semi-opaque foils that can be attached to the glass in order to reduce the visual acuity for the non-amblyopic eye. So the advantage is that the density of the filter can be changed to modulate the degree of deprivation, and this can be useful for tapering treatment while weaning patients from patching. And it has better compliance since the filter is applied to the glass and not to the skin. And this brings us actually to the last question in this small Yosi quiz. So how is penalization carried out in amblyopia? So there is a lot of talk on penalization, but if anyone can just give an easy answer for the same. I'll just wait for 5 seconds before I move on to the answer. So for penalization in amblyopia, you can go for pharmacological penalization or optical penalization. In optical penalization, you have overcorrecting with plus power glasses. And in pharmacological penalization, you can give atropine 1%, which is administered to the sound eye daily or once a week, depending upon the degree and the surgeon's discretion. And it helps in defocus on the amblyopic eye by paralyzing the ciliary muscle and prevents accommodation, resulting in blurred vision. And disadvantages are the drug side effects and the systemic absorption. With that, we end the Yosi quiz. Thank you very much for participating. And I will stop sharing and give the floor to Dr. Anjali, and we can all listen to with rapt attention to her journal club presentation. Dr. Anjali, the floor is yours.
Thank you, sir. Good evening, everyone. Before I start my presentation, I would like to thank Yosi for this incredible opportunity. So as Nupur ma'am said, the title of the article reads, Effectiveness of a Binocular Video Game versus Placebo Video Game for Improving Visual Function in Older Children, Teenagers, and Adults with Amblyopia, a randomized clinical trial. It was published in Journal of the American Medical Association in 2018. The American Academy of Ophthalmology defines amblyopia as the interocular difference of 2 or more lines in a visual acuity table or visual acuity worse than or equal to 20/30 with the best optical correction. So the basic principle of treatment for amblyopia is first the elimination of any obstruction of the visual axis such as cataract. Second is correction of any significant refractive error. And third, and the most commonly used, is the promotion of the use of amblyopic eye. It can be done by 2 ways. First is the occlusion therapy, commonly known as patching, and second is penalization. Now there are newer treatment modalities for treatment of amblyopia. First is the perceptual learning, in which the contrast sensitivity tasks are given with occlusion of the non-amblyopic eye. In that, the newer advance of adaptive optics perceptual learning, where the main focus of the treatment is in treating the higher order aberrations in the amblyopic eye. There are dichoptic treatment. The dichoptic treatment is based on the fact that visual tasks can only be solved if both the eyes are working together. So based on that, a variety of games have been made. The Falling Block is the game on which our study is based on. The other games which include the same is the Dig Rush. Here it is shown in the image. It is an action-oriented adventure game played on an iPad with touch-sensitive screen and with red-green anaglyphic glasses. Here the miner has to collect the gold and put it back into the cart with avoiding any obstacle on the way. Second is the IBIT, which is the interactive binocular treatment game, which is developed by Nottingham team. The third is the Oculotab or Oculopad, here seen in, given in this image, in which the image is presented selectively to the amblyopic eye under open binocular. Then there is a Vivid Vision game, which is played on the virtual reality head-mounted display, and then movies, which comes into concept due to the lack of adherence to the video games. So the newer treatment modality, which is the presentation of high contrast stimuli to the amblyopic eye and different lower contrast stimuli to fellow eye, which is known as the contrast balances, which so it was implemented in a Falling Block video game, which showed promising result in children and adults with amblyopia, which led to the genesis of the question that is a home-based binocular video game more effective than a placebo video game for improving amblyopic eye visual acuity in children older and adults with unilateral amblyopia, commonly known as the binocular treatment of amblyopia using video game Bravo study. Further, the primary aim of the study was to see whether the active treatment leads to an improvement in the visual acuity of the amblyopic eye at 6 weeks. The secondary aim is the improvement of stereopsis and reduction of interocular suppression in the amblyopic eye, compliance and participant acceptability of the home-based treatment, and improvement in the quality of life. It was a double-blinded, placebo-controlled, randomized clinical trial. The total participants calculated were 108 and recruited were 115. The timeline of the study was from March 13, 2014 to June 1, 2016. It was a multicentric study, and the targeted age group were 7 to 12 year, 13 to 17, and more than 17 year. The randomization was conducted through a secure website in a 1:1 ratio. So this is how it went. There was recruitment and screening of the participant, baseline assessment like near vision, distant visual acuity, stereopsis, and everything was taken at baseline. And then they were randomized into active and the placebo group. Before randomization, the participants who have never underwent the optical treatment underwent a optical correction for 16 weeks plus minus 10 days. And then when they showed stable visual acuity, which is 5 or less later changes over 4 weeks, they were randomized into active and placebo group. At week 3 and 6, the assessment was done, followed by follow-up assessment at week 12 and 24. There were 36 participants in each of the 3 groups, 7 to 12, 13 to 17, and more than 17 year, 90% power with 5% level of significance. There was 10% loss to follow-up, and P was 0.05 to detect a group difference of 0.20 logmar or 2 lines. The total recruitment was 108, 54 per arm in the active and the placebo group. The inclusion criteria were more than or equal to 7 years of age, strabismic amblyopia, which was defined as the presence of heterotropia at a distance or near fixation, history of any strabismus surgery, or resolution of strabismus following hyperopic spectacle correction. Anisometropia, which was defined as a difference of spherical equivalent of more than 0.50 diopter between the eyes and difference of astigmatism in any meridian of more than or equal to 1.50 diopter. The mixed mechanism amblyopia had both the component of strabismic and anisometropia. The unilateral amblyopia in the study was defined as the BCV of amblyopic eye of 0.30 to 1 logmar, fellow eye visual acuity less than or equal to 0.10 logmar, and an interocular visual acuity difference of more than or equal to 0.20 log units. The ability to align a dichoptically presented Nonius cross within the screen area of the iPod touch device was also measured before starting the treatment. The exclusion criteria was a myopia of more than 6 diopter, alternative strabismus, deprivational amblyopia, previous intraocular surgery, coexistent ocular pathology, and any known neurological anomalies. The primary outcome was change in the distant visual acuity of amblyopic eye from baseline to 6 weeks. The secondary outcomes include changes from baseline of DVA, near vision, stereopsis, angle of strabismus, interocular suppression, interocular contrast of the amblyopic fellow and both eyes at 3, 6, 12, and 24 weeks. In addition to that, they also measured the treatment compliance and acceptability at 3 and 6 weeks and any change from baseline in quality of life. So this is how the active game looked, and it showed different contrast to the amblyopic and the non-amblyopic eye. This is the placebo game with similar contrast for both the eyes. And this is how the non-ears cross alignment looked like. So every participant has to align this cross before getting randomized on the screen to compensate for any small angle of ocular misalignment and to assess binocularity. And the fellow eye contrast in the active game used to increase proportionally by 15% each day if the game was played at least 15 minutes and a high score of at least 1,000 points was achieved the previous day. So the distant visual acuity was measured with the ETDRS protocol. The near vision was measured at 40 centimeters with Sloan letter near vision. The stereopsis was measured with 3 methods versus the RAND preschool stereo acuity test, the TITMUS, and an iPod-based stereo test. The ocular alignment was measured with cover test, angle of strabismus with prism alternate cover test, the binocular sensory status with 4-dot test, and the interocular suppression with the iPod-based version of the dichoptic global motion test. The treatment acceptability was measured with the modified amblyopia treatment index. These are the questions that were in the modified amblyopia treatment index. It consists of 20 Likert type question with responses ranging from 1 to 5, 1 being strongly agree to 5 being strongly disagree. The quality of life with brief version questionnaire, the treatment compliance and fellow eye contrast with the iPod-based video game software and written diary. The primary hypothesis was that the active video game would improve amblyopic eye visual acuity when compared to the placebo group. The test was done by analysis of covariance. The intention to treat approach was used and analysis were performed using SAS version 9.4. The result for RAND test and the Worth 4-dot test were combined to form a binocular function score for proper analysis. There were 51 participants were randomized at the study entry and 64 after the optical treatment. 56 were randomized to the active and 59 to the placebo group. Out of these 115 participants, about 89 participants received previous occlusion and penalization therapy, but still had residual amblyopia. This is how the randomization was done, 56 in the active and 59 in the placebo group. Here at the 6-week primary outcome visit was completed by 50 participants in the active and 57 in the placebo group. So the baseline characteristics of randomized participants summarized by age group. Here we can see that in the group of 13 to 17 years, the sample size is less. So they recruited more samples. They could not get enough participants, so they recruited more participants in the 7 to 12 and 18 plus age group. The prior amblyopia treatment and the participants included optical patching and atropine penalization. Here are the histograms showing fellow eye contrast in the active video game at baseline, 3-week follow-up and 6-week follow-up. Here at 3-week, about 31 participants, and at 6-week, about 36 participants achieved a fellow eye contrast of more than 0.9. The primary outcome, amblyopic eye distance visual acuity at 6 weeks, showed that the distance visual acuity from baseline in the active group was 0.06, which is about 3 letters, and in 0.07 in the placebo group, which is about 3.5 letters. There was no statistically or clinically significant difference found between the two groups. The secondary outcomes at 6 weeks, the mean binocular function score was 0.23, and in the active group, and 0.25 in the placebo group, and the differences between the group and changes from baseline were not statistically significant. So here, the video game treatment compliance at 3 and 6 weeks was also measured. They defined the compliance as at least 25% of the minimum prescribed dose, or at least 10.5 hours at 6 weeks. So they found that about 36 participants in the active and 49 participants in the placebo group met the study definition of compliance, which is more than 25% of the minimum prescribed dose. There were no participant reported diplopia. 2 participants in the active and 1 in the placebo group reported transient asthenopia when playing video game. So the active and placebo group showed small visual acuity and stereo acuity improvement and did not significantly differ on visual outcome. So the previous laboratory-based studies of contrast balancing treatment found mean amblyopic eye visual acuity improvement of 0.15 to 0.35, while this home-based study showed an improvement of just 0.08 to 0.11. So this difference was attributed to the supervised environment in the laboratory study. Along with that, in the home-based study, the video game interval was cut short into several short sessions to fit around other activities. While in a laboratory-based setting, there were dedicated 1 to 2 hours of block games which were played by the participants. The mean compliance of the active group was worse than the placebo group. Treatment acceptability was similar between both the groups, and iPod-based dichotopic global motion test was somewhat unreliable. So the other studies which were performed based on similar games were the first is the effect of binocular patching game versus part-time patching, in which there was improvement with the video game, but it was found to be inferior to the patching. Another trial for the binocular dig rush game was done, which showed no benefit in the visual acuity. An RCT of video game and interactive game was done with the iBit game. It showed similar result and showed no significant difference. An evaluation of the role of monocular video game play as an adjuvant to occlusion therapy was done. It was found that the video game along with the occlusion may enhance the visual acuity recovery in 6 to 14-year age group. So the author concluded that the specific binocular falling video game did not improve greater visual improvement in older age group, and development of more engaging video game and better compliance monitoring is required. The limitations of author were the inability to monitor participants' and attention at the video game and whether participants wore anaglyphic glasses correctly. So analyzing the article by the Mari method, in the method, the study question was well defined, the sample size was adequate, 115 were recruited. In the inclusion and the exclusion criteria, the response to the previous occlusion or the optical treatment was not properly mentioned. Reason for failure of the previous treatment is also not mentioned. And if they excluded or included the strabismic amblyopia, in which the sensory amblyopia was included or not, is not mentioned. The study period is well defined, which is 2 years, 3 months. Assignment, the randomization was done with the secure website in a 1:1 ratio. It was a double-blinded study, and the unmasked staff member allocated treatment, set up initial fellow eye contrast and game difficulty, and confirmed the ability to play. So the participant and the observer were unaware of the group they were allocated to. The confounding variables for any missed intraocular pathology and the sensory strabismus included or excluded from either of the group was not shown. The study was funded by the Health Research Council of New Zealand and Hong Kong Health and Medical Research Fund. In the result, the predefined primary outcome, which is the visual acuity of amblyopic eye at 6 weeks, was properly analyzed. Accurate and precise measurement of outcomes were done. All the secondary outcomes were precisely measured. In the result, the primary outcome was adequately analyzed. There is no mention of the follow-up at 12 and 24 weeks, and response to prior occlusion therapy is not mentioned. Along with that, they could not get enough participants in the 13 to 17-year age group, and so regression analysis could not be done. Interpretation, there was no participants who reported diplopia. Only 2 participants in the active and 1 in the placebo group reported transient asthenopia. Result cannot be extrapolated to all the population, and the data was insufficient as not equal participants could be recruited to all the 3 groups. Finally, I would like to conclude the presentation with a few interpretation of my own. It was a double-masked study with adequate sample size, duration of study, and randomization. iPod-based stereo acuity test, which was one of the method to measure stereopsis, the principal criteria of which were not mentioned clearly. Third, the prior occlusion therapy, was it tapered or was it stopped suddenly, is not being mentioned in the study. Finally, the very important criteria, which is the cost of the video game, for us is not mentioned properly. Lastly, no clinical guideline for the video game is mentioned as to when to start the video game, in which group it should be started, and when to stop it and how it should be stopped is not being clearly mentioned. With that, I would like to end my presentation. Thank you.
Thank you so much, Dr. Anjali. I think you've done an excellent job in lucidly breaking down the presentation for the audience. With that, I would like to invite Dr. Rohit Modi, sir. He is our statistical and research expert for this evening. Dr. Rohit Modi is a fellow trained in vitreoretina and uvea, and he is a vitreoretina uvea specialist specialist with special interest in biostatistics. He is also the director of Centra Clinic and Hospital in Mumbai. With that, Dr. Rohit Modi sir, I'd like to invite you to the platform to share your expertise on the paper from the research statistical standpoint.
Yeah, hi. Thanks, especially Dr. Nupur, Dr. Anujit, and the whole Yosi team for making me a part of this wonderful initiative. I will just, share my presentation.
Absolutely, sir. I'll just.
Yeah, is it see?
It's visible, so you can put it in.
Yeah. So I am basically an ophthalmologist with a little bit of interest in stats. So I do make mistakes when analyzing the paper. So would be happy to hear comments from other panelists as well. The key takeaways, I wouldn't get beyond my retina or category. So the pediatric ophthalm part, I will leave it to the other panelists. But with respect to the statistics, I believe the first thing which I was very happy was a study with non-significant p-value was published. Many a times editors, reviewers are biased towards papers which have significant p-value, and that is the one which encourages authors, to somehow get the paper through, get at least that p-value less than 0.05. So it's a very good thing from the journal, editorial team that they accepted a paper with non-significant p-value. Another thing which is there, if we read the paper in detail, they have taken the efforts to mention the confidence interval. Again, that's a very good thing, because confidence interval gives us a range of the result. Let's say if you are measuring intraocular pressure difference between two drugs, and we know that at an average, the drug would be lowering 10 millimeters of mercury. But if you look at the confidence interval, the range would be something like from 2 to 20. Then we know that in some cases, the pressure lowering effect would be as low as 2. So, that gives us a better idea and helps us to implement in practice rather than getting a single value, which a p-value would give us. Another thing is statistical tests applied were appropriate. I'll just elaborate on the few aspects which I found interesting in the paper. And another important thing which I really liked was the authors have shared their insight on how the sample size was calculated. This is very, very important for any one of us who's planning any prospective study. RCT is a later step, but any prospective study or even retrospective study, if we show sample size calculation in our methodology, that increases the value of our paper. So, a few things which we need to focus when we are doing the sample size calculation, like the authors did, was first understand what kind of measurements we are going to do for the data, whether it is quantitative or categorical. Quantitative would mean something like measuring somebody's intraocular pressure, weight, height, it gives us a number. Categorical would be something like, mild, moderate, severe NPDR, so on and so forth. And then what kind of size of effect? They have clearly mentioned they're looking at 2 lines of difference. So before starting the study, we need to define what difference, if I find in both the groups, I'll include this kind of intervention in my own practice. What kind of, let's say 2 drugs are there, and one drug is 10 times more expensive than the other one, and we are thinking of using that in our government supply. And the difference in the better one, the costlier one, is just 0.5 millimeter of mercury or 1 millimeter of mercury. We may not actually prescribe that drug to the patient. So what's the size of effect? What we are looking at in that particular comparison is important. Then the alpha error, that's the falsely rejecting a true null hypothesis. Now, this is a very important thing to understand, because if we falsely reject, in the sense, there was no difference and we found a difference, that's what the alpha error is, because this can change the clinical pattern. And this is what we mean by p-value or probability value. Now, traditionally, it has been mentioned as 0.05, but it's not a sacrosanct. It is not something what Bible, Gita, or Quran says. You can decide on your own. Now, let's say there is a treatment which is coming for retinitis pigmentosa. I would be happy to have a p-value of 0.2 also, 0.25 also, because there's no treatment much available for retinitis pigmentosa. But whereas, we are looking at something which prevents endophthalmitis post cataract surgery, and the rate of endophthalmitis is something like 1 in 2000 or 3000. So there I would want a p-value of 0.01. So it again depends upon what kind of study, what kind of research question you're asking upon. And again, the last thing is probability of failing to reject a false. So there is actually a difference in two groups, but we cannot able to find it out, and that's known as a beta error. So that is typically kept at 80 or 90%. The author had kept it at 90% in this study. So that was appropriate. Another thing what was interesting was intent to treat analysis. We need to understand, there were certain dropouts in the study, or some of the patients actually didn't play the game for the amount of duration which was required. And intent to treat basically calculates, takes in those people also, because let's say you have randomized in two groups participants, but in one group 20 dropouts are there, the other group 10 dropouts are there, but 20 dropouts would skew the data in one group and the other group, and it would fail the randomization, and that's where the intent to treat analysis helps us. For this example, let's say there is a medical management for a particular XYZ disease, and a new surgical technique has come in, and we want to know whether surgical plus medical versus only medical is effective. And here are two groups. We randomize in the A group where we are doing a surgery. In the B group, only medical management is there. And before the surgery is done, 15 patients out of 100, they succumb for some reason. So they have a waiting period of 6 weeks. Before that, they succumb. And in the medical management group, in the first 6 weeks, 15 succumb, and following surgery, 15 succumb. So, and when we compare the data in the two groups, we may think that if we do surgery, and if we are excluding the people who had succumbed before the surgery, we will get a data showing that there is an apparent effect. There is a relative risk reduction of 41%, and that's huge. But if we look at the data, this 15 people, if we include, will get a relative risk reduction of 0. That's why intent to treat analysis is really important. Another thing which the authors did, which is kind of a fallacy, is last observation carry forward. Now, what happens is, as the participants in a longitudinal studies, when we have multiple measurements being done, they start dropping out. The last measurement is carried forward till the end of the study. Let's say the study duration was 6 weeks or 12 weeks, and the participants drop out at 4 weeks. So we'll carry that 4 weeks result at the end of 6 weeks and analyze it, so that the randomization which is done for both the groups is kept intact. And like we saw in this study, in the active group, there were a greater number of dropouts as compared to the placebo group. Now, I'm just giving you an example. What is a fallacy in this methodology? If there is a new drug versus an old drug for type 2 or a placebo for type 2 diabetes, and the study question is that how much lowering of glycosylated hemoglobin is seen. Placebo group, obviously the glycosylated hemoglobin will rise. Treatment group, let's say assume it decreases substantially at 3 months, but the drug's efficacy reduces beyond 3 months and it starts rising slowly. The company guys are smart. They terminate the study at 3 months, stating that it is unethical because the placebo group, the glycosylated hemoglobin was rising, and they carry the last observation carried forward to prove that a drug is effective. In reality, the drug may not be as effective as a claim by the company. So it can give us a misleading data. Thank you.
Thank you so much, sir. That was an excellent presentation, especially the examples. I think as residents and fellows, we tend to ignore biostatistics when we go forward, because we usually have someone helping us with it in our college and our universities. But I especially love the reference of retinitis pigmentosa and ENDOF, and how we make a mistake when it comes to p-value, and we always have this assumption about a lower is a better statistic. With that, we believe that it's important to give credit where credit is due. And for this article, I would like to invite Dr. Smita Kapoor ma'am to share the positive aspects of this paper. Dr. Smita Kapoor completed her residency at Kasturba Medical College, Manipal, and followed by a fellowship at the prestigious Shankara Eye Hospital, Coimbatore, and at the New York Eye and Ear Infirmary at Mount Sinai, where she gained experience in her subspecialty. She has presented a number of papers, posters, and videos at national and international conferences and won many awards for the same. Alongside, she has many publications credited to her name in index journals as a reviewer in many national as well as international forums. With that, Dr. Smita ma'am, I invite you to share the positive aspects of this paper.
Good evening, everyone. Dr. Anjali has analyzed the article very well, and Dr. Modi has given out the positive aspects of the statistics also. So I will just give out a few other merits of the study that have not been mentioned by them. So coming to the first point, the data was collected from multiple hospitals across the world, that is New Zealand, Canada, Australia, and China. So the benefits of a multi-center trial include a large number of participants, different geographic locations, the possibility of inclusion of a wider range of population groups, and the ability to compare results among different centers, all of which increase the generalizability of the study. The study selection criteria was described in a detailed and precise manner. Eligibility criteria and visual acuity cutoff were standardized using the ETDRS protocol. Patients who had not worn glasses were given correction for at least 16 weeks before including them in the study. And only those patients who had stable visual acuity for over 4 weeks were included. So this excluded the chance of any confounding by spectacle correction. An unmasked staff member was used to set up the contrast and difficulty levels of the video game, and randomization was done by a secure website in a 1:1 ratio. So this prevented any selection bias and also eliminated the source of bias in the treatment assignments. We are all prescribing new virtual reality systems and as treatment for refractory amblyopia, and we all know that the compliance is not very good because children get bored of playing these games over and over again. So the 6-week duration for the video games was sufficient to check the effectivity. Though the compliance is usually better in a hospital-based setting, home-based treatment is much easier to follow because of convenience. Multiple short sessions could be fit around the other activities, and probably that was the reason that patients did not experience a lot of asthenopia in this study. And coming to the last point, the outcomes in the study were measured using a rigorous double-masked protocol. So the advantage was that the experimental bias in the study was reduced. So these are the basic positive points that I could take away from the study. Thank you.
Thank you so much, Smita ma'am, especially for highlighting the points on randomization as well as masking. Ma'am, could you not share the screen? I'll just. Thank you so much, ma'am. With that, I'd like to invite the next member of our expert panel, Dr. Kirandeep Kaur ma'am. So we at Yosi Jc believe that we should also point out the negative aspects of a paper because that helps us learn from the mistakes made and helps us discuss more scientifically how to go forward. Dr. Kirandeep Kaur completed her fellowship from Aravind Eye Hospital, Pondicherry in 2020. And she has published more than 200 peer-reviewed articles in various national and international journals, as well as being a reviewer in many international journals, and has received maximum publication awards from the Aravind Eye Care System in 2019 and in 2020. And her areas of interest include myopia control strategies, digital eye strain, amblyopia management, and complex strabismus management. She is also an excellent teacher and a mentor. I have had the good fortune of interacting with her at Aravind Eye as well. With that, Kirandeep ma'am, I would like to invite you to discuss the negative aspects of the paper.
Thank you, Dr. Anujit, for the warm welcome. And thank you, Dr. Gunjan, for giving this kind opportunity. So I'll just quickly brief the negative aspects, whatever I can understand from my experience. So first of all, in the introduction itself, I felt like the lacuna was not very well defined. So whenever we are trying to like write a paper, the most important thing that anyone wants to know is what is new in the study. So the introduction in this particular manuscript is very small. It is limited to the treatment options that are available. But it will be very great whenever we are trying to write a paper, we should try to highlight it as something new, what we are doing, whether it is a new methodology or a new exercise that we are going to study, or whether it is a new population in which we are going to do the study. So that was missing in this particular study. Then next, coming to the methodology part, like as already highlighted by Dr. Anjali, the compliance was not adequately monitored. So had this been conducted as a hospital-based study, so observation would have been better. And ultimately the results will be, we will be able to understand in a much better way the role of dichoptic exercises in the amblyopia management if the compliance would have been better. Then the next point is, it is mentioned in the study that the missing data were replaced using last value that was carried forward. So this is ideally not an ideal thing to be done, because what the ideal thing will be, like these cases should have been excluded from the study, because these can lead to a possible bias if we carry forward the missing data. So wherever the patient is not able to come for that visit, there always should be a window period for that. And if the patient is not coming within the window period, these patients should have been excluded, which was missing from the present study. Then next point is, patients, they were given an option of continuous 1 hour gaming session or multiple split sessions. So what I believe is, whenever we are trying to understand the utility of a particular activity like dichoptic games in this particular study, so it should be given as a homogeneous methodology to all the study participants to be able to understand in a better way, or these should be divided into 2 subgroups. Then last is from the results part, like they included 89 patients with prior occlusion, but in the results part, it is not mentioned like whether there was a difference seen in the patients who were fresh or patients who had prior amblyopia therapy. And moreover, as Dr. Anjali highlighted, like what was done to the patients who were doing occlusion, was it tapered or stopped continuously, or whether they continued along with these games, it is not mentioned clearly. And the last point that I would like to highlight is the deviations. Like it is mentioned in one patient, there was the authors noticed an increase of 6 prism diopters deviation, and in 6 patients there was a decrease. But whether it was an ESO or EXO is not mentioned. So if that is mentioned, it will help us in understanding the clinical utility, like in what patients we should be trying to omit these type of exercises. So that is also missing in the study. Thank you.
Thank you so much, Kirandeep ma'am. And it's always a pleasure listening to you, especially when you're adding in the clinical points that can be taken from the study and how that is of more relevance to us when we are practicing clinicians. With that, I just share my screen once again. And in last but not the least, invite the last member of the expert panel, Dr. Asha Samdani ma'am. Dr. Asha Samdani is currently a consultant at Virinchi Hospitals, Hyderabad. She has done her MD in ophthalmology from the All India Institute of Medical Sciences and her senior residency in oculoplasty, squint and neuro-ophthalmology from AIMS Delhi as well. I would like to invite ma'am to share the latest developments in this current topic.
Thank you so much. And that was an excellent presentation, Anjali, and excellent sum up by Dr. Smita and Dr. Kiran ji. Thank you for the kind introduction, Dr. Anjit. I would like to share my presentation now.
Sure, ma'am. Please go ahead.
So it's visible, right?
Yes, ma'am.
So I'll be discussing about some advances in amblyopia therapy. So as you know, the management of amblyopia, we have already discussed about the occlusion therapy, which is the conventional treatment, and penalization and active vision therapy, which have been very well discussed by Dr. Anjali. This is a liquid crystal glasses. So this has an electronic shutter, and it is controlled by a microchip incorporated in the optical refractive lens. So you don't have to use an occlusion in specific. It is depends on the electric polarity, and it has a gel-like liquid with which it can actually create an occlusion-like effect. So this is one advance, and the coming, yeah, penalization. So penalization, we have also already discussed partial penalization. So coming to, I'll go to the pharmacotherapy. So I'm trying to exclude the topics which have already been covered. Pharmacotherapy, levodopa and citicoline are few advances. So levodopa, as you know, it's dopamine precursor. It can permeate the blood-brain barrier. So, and it has also showed some beneficial effects as adjuvant to occlusion in ATS 14, above 8 years of age. In an RCT, it showed there is no improvement reported in 7 to 12 years, but above 8 years, it has gotten a promising result. And citicoline again, it activates the biosynthesis of phosphatidylcholine in the neuronal cell membranes. So it basically increases the levels of neurotransmitters. Again, it has stabilized the effects of patching. So even this acts as an adjuvant to the therapy. This is not complete replacement of the therapy, but yes, this has stabilized the effects of patching from 4 to 13 years of age. And donepezil and citalopram. Donepezil is a cholinesterase inhibitor. It affects the same thing. It acts like the previous one. Modulation affects the excitatory inhibitory balance in the visual cortex. So even a pilot study in adult amblyopes, there is no improvement in the perceptual learning. And citalopram is an SSRI, and this has showed some favorable results. So active vision therapy has already been discussed by Dr. Anjali. As the video games, it's a form of, it is the next generation technology. And amblyopes less than 7 years, it's not much of benefits because greater than 8 years, they'll be able to comply well with the games. So in this active vision therapy, there are monocular video games. In monocular video games, you can see that there is a significant visual recovery in anisometric amblyopes, especially. Anisometric amblyopes are having very good prognosis with these games, less than 10 years. So active vision therapy dioptics, again, I would like to skip this because it has been discussed extensively by Dr. Anjali. So this is there are several types of dioptic therapy, like she has already enumerated, like 5 to 6. So this is just, this has been showed by Anjali again, Tetris game. And binocular iPad therapy. In binocular iPad therapy, visual acuity improvement has been noted in both the groups. In here, what we do is we do a 2 hours patching, and then other thing is 1 hour of binocular iPad game in 5 to 13 years. This is done for 4 months. So the what are the alternative technologies? IBIT technology, VR-based display system, and software. In this, the software stimulates the amblyopia without compromising the vision in the fellow. So basically, this is the binocular vision therapy. And now I'll be liking to discuss about binocs. Again, this is a form of dioptic therapy itself. This is a cloud-based program, and it can either be office or home-based. The only requirements what you need is an internet connectivity and LED screen, and it's quite easy to operate. And these are the study clinical results. So almost 150 subjects, we have taken 150 subjects at the age of 7 years, and there is a 4 logMAR improvement in visual acuity in almost 30 sessions. So these are the clinical results. Almost 90% have even developed gain stereopsis as well. So this is the one case which I wanted to discuss. This is a 23-year-old female patient with anisometropic amblyop. As I told you earlier, anisometropic amblyopes have very good prognosis with these dioptic therapies. So she started with a vision of 6.6 and 6.24, and the stereopsis was absent. And after 30 binoc sessions, we have gotten a visual acuity of 6 by 7.5 and N6, and fusion also has developed, and 60 seconds of arc for near and 75 for distance. And this is a very good result. What are the limitations of dioptic treatment is you need a bifoveal fixation and motor alignment is a must, and eccentric fixators may not have very good results. This is a second case. In this again, 6 by 6 and 8 degrees of exophoria and 400 seconds of stereopsis for near and absent for distance. This is a case in which we have actually planned an IOL explantation in a multifocal patient where he was facing some visual glare and symptoms. So after binocs, I just included this because it has some extended uses as well, not just in amblyopia, which is interesting. So, and after like a few sessions, 10 sessions of binocs, he has developed, even his exophoria has gone down to 2 diopters, and his glare and stable images have also been developed. So yeah, this is a brief, like how binocs look like. It's a telehealth software. And one more thing is revital vision. So I have included this based on feedback by Dr. Smita. It has been extensively done at their center, Vision Eye Center. And so this relies on the visual and cortical impact of the GABA patches. So these GABA patches are sinusoidal gratings, as you can see here. And these act as a psychophysical stimuli. So these GABA patches are presented in different frequencies, arrangements, and also in contrast levels, and also the orientations, and even with specific durations. So these stimulate the visual centers within the cortex. And quoting a study, so this is how a patient goes through the GABA patches, and 54 adult amyloid patients are included, and they are randomized to this NVT, neural visual therapy, and also the placebo vision. 2 to 4 weekly treatment sessions have been given, and they last approximately 30 minutes each. So the visual acuity, even in this, has improved almost to an average of 2.5 lines in the treatment group, with an increase in the contrast sensitivity as well. There was no improvement in the control group, and the acuity has even sustained after 12 months of the cessation of the therapy. And how does this program work is, this is a unique vision training web app that stimulates the brain visual cortex, and the sessions are almost 30 to 40 training sessions and 30 minutes each, and this is a 2 to 3 month program, and it can be performed 3 to 4 days at home on patient's computer. So again, this is a cloud-based platform in which you will be able to access, the patient will be able to access, and the optometrist or someone who is from the Revital Vision, or even they will be having a look. So you can give the feedbacks and updates. So the inclusion criteria is age 9 and up, because this need compliance. Less than 8 years, they may not be exactly able to cooperate with this. Stable vision and has an access to computer. Exclusion criteria, again, it has unstable vision and eye deviation exceeding 8 prism diopters, and epilepsy and chronic migraine and ADHD. So the treatment protocol, I have all, if anisometropia is higher than 3.5 diopters, then you have to prescribe a contact lens. So before starting the therapy, you need to fully correct them either with glasses or with the contact lens, and that then is when we start the treatment. The dominant eye is blurred with a semi-transparent tape, and the bilateral amblyopia, we begin with the bilateral treatment, and there are almost 40 training sessions, and the follow-up examination is again recommended after 20 to 40 sessions. Now I'll be going to the next therapy, that is orthoptic therapy, which we have recently started in our center as well. It has been invented by Dr. Santan Gopal, and he has been playing quite an active role in developing this. So the prerequisites of an orthoptic is you need an ambient light, 1 to 1.5 meters of room, laser pointer, eye patch, and voltage stabilized power to mission. These are actually all important because you kind of need to set up the thing. See, like if it's not 1.5 meter, you can't maintain the distance. So this is how the orthoptic looks like. This has a central red light, as you can see, and there are almost surrounding lights of 8 lights of these are the green ones. So these has 2 parts. The total time of one session is 40 to 50 minutes. So you follow the following light with the laser. So what happens is you have to take a laser in your hand, and then you need to the red one keeps blinking, that is there constant, and the green one, it changes, and you have to follow the light with the laser with your hand. And for the good eye, you do it for 2 minutes, and for the lazy eye, you do it for 20 minutes, and both eyes, you do it for 5 minutes. Now coming to the part 2, you count the peripheral lights. So here the red light is off, the central red light is off, and the peripheral white lights, they keep blinking. So you need to count 1, 2, 3, how many times ever you see that. Okay, for the lazy eye, you do it for 400 times, and for the good eye, you do it for 200 times, and binocularly, you do it for 200 times again. So the total time is 40 minutes to 1 hour. So this is one patient in which he has been diagnosed as amblyopia post eye injury following corneal cataract repair done, and the number of sessions are almost 55 plus. The vision before therapy is 3/60 and 48, and the perception was absent, and the post therapy it is 6/9 parts, N12, and 200 seconds of arc. And another patient of refractive amblyopia, the total sessions were 9, and there was a vision of 6/9 parts, N6 blur, and 200 seconds of arc. Post therapy, he was 6/6, N6, and 40 seconds. Even one of my patients who had a residual exotropia with diplopia, after 1 month of the surgery, I have done this orthoptic, and even I have got like good results. So to summarize, this is how I have presented few things. I hope I am able to convey what I wanted and make you familiar with few of the advances. I would any feedback.
And thank you so much, ma'am. That was like a feast of recent advances in such a short span of time. And I personally really appreciated that you not only shared them, but you also spoke about their promising nature with the studies that showed the results and that something is coming good out of it. And it's just not something that is happening in the background. And with that in mind, I'd like to share the final part of the presentation. The Yosi Journal Club, in its heart and soul, is actually a mentor-mentee program where a mentor guides a mentee throughout 1 month before he or she presents her journal club. And for this month, we have Dr. Gunjan Saluja ma'am, who has been tirelessly helping Dr. Anjali with her presentation. So Dr. Gunjan Salula is a consultant of strabismus, oculoplasty, and neuroophthalmology at the Bhartiya Eye Care Center at Chhattisgarh. And she has done her MD in ophthalmology from the RP Center, followed by a senior residency in strabismus neurophthal oculoplasty at the RP Center with 50 and more publications in national and international peer-reviewed journals, as well as presented papers and posters in them as well. She has 12 awards to her credit, which includes the International Ophthalmologist Award by the American Academy of Ophthalmology and the Best Outgoing Senior Resident Award from the RP Center at AIIMS. Dr. Gunjan Saluja ma'am, I'd like to invite you to summarize the results of the study as well as share your views on the current study.
Definitely. Thank you for the opportunity. And in short, I'll just cover everything, whatever we have discussed so far. So the take-home message, which I feel, is that it's a well-conducted study and it has been done thoroughly. The protocol was very well-defined. And even patients were given 16 weeks to adapt themselves for the refractive correction. It was a blinded study. And amblyopic eye saw 100% contrast and the fellow eye was shown a lower contrast. And contrast of fellow eye, as we had discussed earlier, that it was increased by 15% if the patient was compliant and he was playing games for 15 minutes. And also a high score was like encouragement to the patients to play more of them. One very good thing which I found was that they also provided reimbursement to the patients for traveling, spectacles, and contact lenses, which is one very important thing which is missing in most of the studies. Now coming to the But what the question remains, even after so much discussion and even after such a good study, is that it has shown no significant difference between the two groups in terms of improvement in visual acuity, stereopsis, and any other parameter. So the question now rises, the hype which is created in the recent times around these games, are they really effective? Their effectiveness is still questionable, as we do need a lot of data before we apply them to a clinical practice. Also, the translation of research and clinical practice remains a challenge. We have to have clear guidelines on how to start the treatment, when to start, and how to stop. It is going to take time, and gradually it might come into our practice. The last thing, especially if we sit in a remote area, is the accessibility. How are they going to assess? Because many a times patients don't even have internet access in remote areas. So these things have to be made within the device itself, and they have to be made affordable also, smartphone friendly, and a feature of compliance monitoring should be added to these softwares. Free sessions should be included, and patients and parents should be warned about the risk of habit development and asthenopic symptoms with these games. The future is to develop affordable, easy to use software to target the general population with widespread acceptance, and long-term studies which large sample size are required. The games have to be better, they have to be interesting and interactive for better compliance. The future hopes are on orthoptic, virtual reality systems, and revital systems, as Dr. Asha had just discussed. Thank you.
Thank you so much, ma'am, for a short and a crisp summary of the presentation, as well as the take-home points, which are the most important part of the discussion. With that, I'd like to open the floor for any audience questions that may be there. I'm sure a lot of the audience is watching on YouTube, so you can put your questions there, and if we see any, we would definitely share them over here. And while we get any audience questions, I would like to give the certificates out to our esteemed panel. So starting with Dr. Anjali Maheshwari, thank you very much. This is a certificate as a speaker. Thank you, a very warm thank you to Dr. Rohit Modi for being the research expert today. A very warm thank you to Dr. Gunjan Saluja ma'am for being the monthly mentor for the Yosi Journal Club for the month of September. To Dr. Smita Kapoor ma'am for being a panelist at the Yosi Journal Club. Dr. Kirandeep Kaur ma'am for being a panelist at the Yosi Journal Club. And Dr. Asha Samdani for being a panelist at the Yosi Journal Club. If there are no more questions, I would like to invite all the audience for the Journal Club for the month of October. The topic is going to be retina and the presenter is going to be Dr. Isha Acharya. With that, I'd like to hand over the floor to Dr. Nupur Goel ma'am for the vote of thanks.
Thank you, Anujit. That was a very, very fantastic session. So at the outset, I'd just like to thank, first of all, just a second, I'll just share my screen as well. So yeah, so at the outset, I would like to thank Dr. Sonal. She couldn't join us today. She's a little under the weather. For starting these Journal Club sessions, she's the president Yosi, and giving all the opportunity for these wonderful sessions. And then I would like to thank Dr. Anujit, who's my co-moderator, for brilliantly moderating the entire session and being a tremendous help throughout. Then I'd like to thank our presenter, Dr. Anjali, for an excellent presentation. Well done, Anjali. And then Dr. Rohit Modi for the wonderful the statistical examples that he gave, making it so simple to understand the entire statistical critique of the article. Then I'd like to thank Dr. Gunjan for being the wonderful mentor. Especially, I would like to give credit to her for actually orchestrating the entire session, coordinating with the panelists and setting up the, thank you, Gunjan, for a wonderful, wonderful coordination and a wonderful setting up the whole flow to the session. Then I'd like to thank Dr. Smita for beautifully highlighting the positive aspects of the article. Dr. Kirandeep for wonderfully highlighting the negative aspects of the article that just, both of you just added. I think it was the whole purpose of the Journal Club was beautifully done by you, and Dr. Asha for so nicely bringing out the recent advances. That's the idea of the Journal Club. You discuss the merits, demerits of the article being discussed, and then you also discuss what are the recent advances and what is the way forward. And of course, the audience who stayed with us till late night and have participated. Again, I'd like to thank Anujit, I forgot to mention, for the excellent quiz that you prepared. So thank you all. And so this is our official email ID for the Journal Club sessions. Any sort of feedback or any suggestions, you can always mail to us, you can write to us. If you are interested in participating or presenting in the future sessions, you can mail to us. And we will be on and off circulating the Google form in the Yosi groups and otherwise. So you can fill those forms also if you're interested in presenting. So with this, we come to the conclusion of our Journal Club session. Thank you, everyone. And before we disperse, we can have a quick mandatory click with all the panelists and the speakers. So yeah, so you're ready, Anujit? Yeah, we can have the we can have the Yosi fine. Yeah.
Just a minute, ma'am. I'll just take a screen.
Somebody's missing. Kirandeep is not there. She's logged.
Just a minute.
Yeah.
Yeah. I'll just take it once more.
Yeah.
Yeah. Thank you so much, ma'am.
Thank you.
Thank you.
Thank you, everyone.
Thank
Thanks,
you.
everyone. Yeah.
Good night.
I'll just stop the